Hello and welcome back. So I'll be discussing interstitial nephritis in this video. This will be part 5 in our approach to peripheral edema. So starting off, interstitial nephritis, we'll be discussing pathomechanisms and their clinical correlates in this video, and then in the subsequent video we'll go on to discuss the histopathology and how it is relevant to the diagnosis of interstitial nephritis. So, I'll be covering the topic under the following headings. First, we'll try to understand the mechanisms of acute and chronic interstitial nephritis and how they cause peripheral edema by distinct mechanisms. Then, I'll try to derive the clinical features that differentiate between these two types of interstitial nephritis. Understand the possible causes of acute and chronic interstitial nephritis, specifically, talk about the etiologies that can result in the two types of pathologies. Then understand the clinical considerations that arise during the evaluation of acute interstitial nephritis. Similarly, understand the clinical considerations that arise during the evaluation of chronic interstitial nephritis. And then finally, we'll try to understand the clinical conditions that arise when drugs or toxins are considered as a cause of possible interstitial nephritis, particularly chronic interstitial nephritis. So, as we've discussed previously, the mechanisms of injury are twofold. One is you could have direct tubular obstruction, and we had visualized it during this diagram, as in crystal gets deposited within the lumen of the tubules, and as a result, it obstructs the tubules. Alternatively, what could happen is interstitial inflammatory infiltrate could infiltrate into the interstitium of the kidney and secondarily cause damage to the tubular epithelial lumen lining, and that causes desquamation of epithelial cells into the lumen, causing obstruction. So the final effect of both these processes is the same, it is tubular obstruction. That would be a type of intrarenal post-glomerular obstruction. Okay. Now, having understood that there are two distinct mechanisms, I'll also try to compare it to chronic interstitial nephritis, which is more of a obviously a chronic process where interstitial renal fibrosis predominates, resulting in secondary atrophy of the tubular epithelial cells and therefore a loss of tubular function rather than obstruction of the tubules by desquamating epithelial cells. So, as we've just discussed, in acute tubular interstitial nephritis, we have aggressive inflammatory infiltration of the interstitium that causes necrosis of the tubular epithelial cells and a little bit of interstitial edema, resulting in desquamation of those cells into the lumen of the tubule, finally resulting in a compromise of the tubular lumen. Similarly, you could have direct obstruction of the tubular lumen by crystals or in some cases proteins that get coagulated within the lumen of the tubule. Then you could have tubular epithelial necrosis and secondary tubular edema. But again, this is an inside out process rather than an outside in process. And finally, we have against that interstitial infiltrate, you have an aggressive inflammatory infiltrate. So in the first type of pathology, the infiltrate is primary and the damage is secondary. Whereas in the second type of pathology, the obstruction of the lumen is primary, and then secondarily, as a reaction to that, there is a inflammatory infiltrate or a immune response. In chronic interstitial nephritis, we have interstitial fibrosis and tubular atrophy. And as we go ahead and discuss the pathogenesis of CKD, in a subsequent video, we'll discuss how chronic glomerular damage and proteinuria predisposes to this kind of interstitial fibrosis with tubular atrophy secondary to epithelial to mesenchymal transition within the tubular cells of the kidney, and how that process then eventually leads to CKD. Okay. However, here we are going to discuss primarily regarding those processes where this kind of interstitial fibrosis is a primary process rather than secondary to glomerular injury and persistent proteinuria. Okay. Now, in case of the clinical differentiation, actually differentiating between acute interstitial nephritis and chronic interstitial nephritis is rather simple, because in acute interstitial nephritis, there is an intrarenal post-glomerular obstruction. So, because of that, there is a increase in the hydrostatic pressure within the Bowman space within the glomerulus, and that causes a decrease in the GFR, resulting in, or the glomerular filtration rate, resulting in a reduction in the urine output. So you get an acute kidney injury with the subsequent reduction in urine output and elevation in serum creatinine levels. Along with that, because there is interstitial edema within the kidney, there is a distension of the capsule of the kidney, and this being a acute process, as the name would suggest, you end up getting distension of the renal capsule, which causes a pain. That is a bilateral flank pain in the renal, usually appreciated in the renal angles. In case of a subvariant, that is allergic, so-called allergic interstitial nephritis, where you have a drug inducing a allergic response against the drug and causing renal injury, you also may have peripheral eosinophilia and indeed tissue eosinophilia. But again, these two processes need not always coexist. Then in case of chronic interstitial nephritis, we have loss of tubular functioning, which results in a proximal renal tubular acidosis, and when more severe, results in Fanconi syndrome. Then we can also have nephrogenic diabetes insipidus. Both of these I will be discussing in detail in our evaluation of patients with polyuria, and rather in our evaluation of patients with hypokalemia and patients with polyuria, respectively. I'll let it be for now. But as you can see, the urine output is actually increased in these patients, and they have electrolyte imbalances. Indeed, they have hypokalemia and hypernatremia, respectively. The hypernatremia in this case is secondary to loss of free water from the kidneys. Okay. Now, along with that, they have subnephrotic range proteinuria. So even though the patient is actually volume depleted, they're losing around, 1 to 2 grams of protein in the urine, and this is due to impaired tubular reabsorption of protein rather than anything else. Okay, so unlike what is classically understood about our these pathologies about loss of protein in the urine, about 1 to 2 grams of protein, or normally around a gram of protein, is actually filtered by the glomeruli into the Bowman space per day, and has to be reabsorbed through pinocytosis within the proximal convoluted tubule. And this is a normal process, and therefore, the proximal convoluted tubule being functionally intact is also a factor in maintaining the normal levels of protein, that is less than 30 milligrams that you see in urine in a normal person. So, if you have tubular dysfunction, particularly proximal tubular dysfunction, you end up with some degree of proteinuria. This proteinuria is almost always less than 2 grams, typically around 1 to 2 grams. So, uh, now, the thing is, in patients who have FSGS with secondary, who have secondary FSGS as a result of the injury that has occurred to the interstitium. Okay, and this is also something that can happen. You develop nephrotic range proteinuria subsequently, and either way, the cause of the edema, therefore, in chronic interstitial nephritis is protein loss in urine, resulting in serum hypoalbuminemia, and that is what causes the edema. Whereas in cases of acute interstitial nephritis, obviously we've discussed this under our causes of oliguric renal failure. So this is due to decrease in urine output, resulting in an increase in total body water that subsequently causes a peripheral edema. Yes, so therefore, chronic interstitial nephritis can only cause peripheral edema in the presence of hypoalbuminemia. Otherwise, it is not a valid explanation for peripheral edema. Now, coming to the causes, as in the etiologies or the primary diseases that result in these two pathological processes within the renal interstitium. Now, in case of, so I like to divide these causes as per the general headings under which they naturally fall. So that would be autoimmune diseases, neoplastic disorders, and among autoimmune diseases we have a systemic autoimmune rheumatic diseases, and you have a organ limited autoimmune disorders. So acute interstitial nephritis due to interstitial infiltration within the kidney causing secondary tubular damage. So that is what this column is. Um, can be caused by Sjogren syndrome. Because in Sjogren syndrome we've got a anti-epithelial immune response occurring. Um, That immune response is partially due to anti-epithelial T cell mediated responses, Th17, Th1 responses, and actually, to be frank, more uh, the greater damage is caused by the production of local type 1 interferon and the secondary changes that happen due to such chronic interferon production. The role of the adaptive immune system in causing this type of damage is actually minimal, and that ergo the ineffective nature of immunosuppression in the treatment of Sjogren syndrome in most cases, other than for certain cases of acute interstitial nephritis. Okay. Now, the second consideration is SLE. Now, systemic lupus erythematosus can have interstitial nephritis, but it is present in only about 10 to 20% of cases, and usually is overshadowed clinically by the presence of glomerulonephritis. Now, IgG4 related disease is a pretty valid differential in cases of acute interstitial nephritis, and indeed even in some cases of chronic interstitial nephritis due to a delay in diagnosis. Now, in IgG4 related disease, the patients are predominantly male, and the complement levels in serum are decreased, which is something that is a clear pointer towards the possibility of IgG4 related disease and related interstitial nephritis. Now, because it is chronic, sometimes patients can have polyuria. That is, they have an intact urine output. And also, an important consideration here, which I'll discuss again when we talk about IgG4 related disease, is that the this is the only uh, organ damage or end organ damage that occurs in IgG4 related disease as a result of complement activation secondary to IgG4 antibody deposition. Okay, so IgG4 antibodies classically are thought of as not activating complement. However, at very high pathologically high levels, IgG4 antibodies can actually activate complement. So that is what is responsible for the renal damage here. Now, among organ limited disorders, we have the organ limited variants of these systemic diseases that are primarily causing interstitial nephritis. So, rather interesting variant of this is what we call tubular interstitial nephritis with uveitis. Now, there are certain clinical features that strongly point towards TINU or TINU, that is a male predominance, unlike other organ limited autoimmune disorders. So that is, males are affected three times more often as compared to females. A median age of onset that is relatively young. So this happens typically in adolescents. It has been reported in adults, and adults tend to have a relapsing remitting course rather than a single one-off event. Okay. Now, corresponding to our sarcoidosis, we have granulomatous interstitial nephritis. Now, you would notice that I've not mentioned sarcoidosis as a cause of acute interstitial nephritis. That is because almost exclusively sarcoidosis causes chronic interstitial nephritis and nephrocalcinosis rather than acute interstitial nephritis. Okay. However, granulomatous interstitial nephritis can be a presentation of acute interstitial nephritis, but in those cases, it is almost exclusively organ limited. Then we have idiopathic interstitial nephritis. That is a lymphocytic variant of interstitial nephritis where there is no systemic association. So you find no association with Sjogren syndrome or SLE. Then we also have a rather interesting organ limited renal disease called anti-brush border epithelium disease. Okay, in which you have antibodies against proteins that are basically associated with the brush border epithelium of the proximal convoluted tubule. So that includes your anti-LRP2 nephropathy. Yeah. Now, acute interstitial nephritis due to tubular obstruction is not caused by any systemic or organ limited autoimmune disorder, and that is a very intuitive thing to say. I would think so. I'm not going to go into an explanation for that. Now, in case of chronic interstitial nephritis, sarcoidosis technically can cause chronic interstitial nephritis. Okay, but actually, sarcoidosis primarily causes nephrocalcinosis. That is because in sarcoidosis, you have vitamin D getting activated within the abnormal granuloma that are forming, because the granulomas express 1 alpha hydroxylase, and that uh, results in the formation of 125 hydroxy vitamin D the activated form of vitamin D. And see, normally 125 hydroxy vitamin D inhibits the further activity of 1 alpha hydroxylase, but this is not the case when it is 1 alpha hydroxylase being expressed within macrophages and dendritic cells within granulometer. So as a result, there is runaway production of 125 hydroxy vitamin D, and that is what causes an increase in serum calcium levels in sarcoidosis. Now, unlike PTH dependent increases in serum calcium levels, PTH causes reabsorption of calcium within the proximal convoluted tubule. So, the relative amounts of calcium being lost in vitamin D dependent hypercalcemia vis-a-vis PTH dependent hypercalcemia are much higher. So, as a result, sarcoidosis routinely causes renal interstitial deposition of calcium, and because of that, you end up getting nephrocalcinosis, and that is actually the most common cause of chronic interstitial nephritis and secondary nephrogenic diabetes insipidus in patients with sarcoidosis. Now, in case of neoplastic disorders, it's chronic lymphocytic leukemia, and actually this would be SLL, that is the lymphocytic leukemia variant can cause direct renal interstitial infiltration and cause acute interstitial nephritis. But much more commonly, we have plasma cell dyscrasias, obviously prototypically multiple myeloma, causing myeloma kidney, which is due to coagulation of your light chains that are being produced by the neoplastic plasma cell clone getting coagulated when they bind to TAM Hochwald protein that is produced by the proximal convoluted tubules, and therefore this protein complex actually accumulates within the thin descending and thin ascending loops of Henle, and that causes an obstruction. Okay, so this is the prototype of our interstitial nephritis secondary to tubular obstruction by a protein getting deposited within the lumen. Now, obviously, chronic interstitial nephritis does not happen with any neoplastic disorders. Okay, so essentially, autoimmune disorders, except for the notable exception of IgG4 related disease and nephrocalcinosis with sarcoidosis, do not cause chronic interstitial nephritis. Okay, and similarly, neoplastic disorders do not cause chronic interstitial nephritis. What does cause chronic intestinal nephritis are metabolic disorders and much less frequently genetic disorders. So, metabolic disorders, what I mean by that is the deposition of crystals, that is urate crystals and phosphate crystals within the tubules of the kidney, and that can cause secondary obstruction of the lumen with the process that I've discussed previously. Now, however, metabolic nephropathies, chronic interstitial nephropathies are actually the most common cause of chronic interstitial nephritis. So this includes your nephrocalcinosis, and this is again we need to highlight that this is something that happens very prominently in sarcoidosis. It can happen in essentially any cause of hypercalcemia, but when it is vitamin D dependent hypercalcemia, PTH levels are low because vitamin D inhibits PTH, so renal calcium reabsorption is also decreased. Indeed, when there is hypercalcemia due to, say, direct bone resorption in case of metastasis to the bone, also you get the same process. So calcium levels are high, so that inhibits PTH, and therefore PTH levels are low. So any non-PTH dependent hypercalcemia is much more likely to cause nephrocalcinosis. However, epidemiologically speaking, primary hyperparathyroidism is actually the most common cause of prolonged hypercalcemia, long enough to cause nephrocalcinosis. So, PTH dependent hypercalcemia ends up being the most common epidemiological entity that you encounter as a cause of nephrocalcinosis. However, uh, mechanistically speaking, the relative risk of developing nephrocalcinosis is actually highest when the hypercalcemia is secondary to either an elevation in vitamin D or direct hypercalcemia due to bone infiltration. Now, the other causes include your hyperuric, uricosuric, that is or urate, chronic urate nephropathy, uh, two genetic disorders, that is hyperoxaluria and cystinosis, and very importantly, prolonged hypokalemia, that is a decrease in potassium levels. Okay, now the effects of potassium, a reduction in potassium are actually rather interesting because a decrease in potassium levels actually causes hyperpolarization of resting membrane potentials. Okay, and this rather counterintuitively results in a vasoconstriction within the renal medulla. The reason for this primarily being that with each cycle of smooth muscle activation, the number of voltage gated sodium channels and voltage gated calcium channels getting reactivated increases when you decrease the or when you make the resting membrane potential more negative. Okay. Now coming to the coming to the genetic causes. So there are only two genetic causes. One is sickle cell nephropathy or sickle cell anemia related nephropathy. Again, this would be because the renal medullary vasculature is obstructed by the sickling of cells in sickle cell anemia, of RBCs within in sickle cell anemia. Now, why is the renal medulla specifically affected? Because the renal medulla, as we've discussed previously, has got a much higher osmolarity. Therefore, as fluid passes through tubules within the medulla, it tends to get concentrated. This happens within the tubular lumen as well as within the RBC, within the plasma that is passing within the vasa recta or the blood vessels within the medulla. Okay. So obviously dehydration of RBCs with a tendency to to sickle causes sickling. Okay. The other reason is renal medullary pH is also lower. Okay, and the third reason is that normally only 1% of the renal blood flow supply is actually going to the renal medulla. So the partial pressure of oxygen within the renal medulla is also lower. So that also causes sickling. And once this process starts, any inflammation within the renal medulla also tends to stay there for longer. And as we know, inflammation results in endothelial cell activation, and that increases the interaction of sickling cells and other inflammatory cells within the blood that is passing through the medulla with the endothelium of the vessels of the renal medulla. Okay. Now, these are the reasons why you get renal medullary ischemia in patients with sickle cell anemia, and indeed you can end up developing a chronic interstitial nephritis because of that. Now, cardiomegalich nephropathy is due to a mutation in a gene called FAN1. Okay, it's an autosomal dominant disorder, and this is a gene involved in double-stranded DNA repair, specifically within the proximal convoluted tubule. So, as a result, you end up getting a very specific chronic interstitial nephritis due to primary proximal tubular dysfunction. So this would primarily cause proximal RT followed by Fanconi syndrome. Okay. Now, importantly, the name itself gives you a clue about what you would find on the biopsy. Okay, so what you find is very large size nephrons. Okay, and this is related to the fact that cell division is important for and indeed essential for the embryological development of the your nephrogenic bud within the mesenchyme of the future kidney. Okay, so that is something that we'll discuss maybe in a later discussion, particularly in relation as pertaining to CKD. But that is what you find on the biopsy. Okay. Okay. Now, in patients with chronic interstitial nephritis, which is actually unexplained, if you have elevation in total body levels of lead, it has been found that chelation of lead found actually decreases the rate of progression of CKD. So, and this is a relatively common situation that we encounter while evaluating patients with chronic interstitial nephritis. It is we don't find a cause, and in that situation sometimes it is some okay, in most situations when economically viable, we can test for evidence of elevation in serum or total body lead levels, which can be done through a lot of measures which we'll discuss under toxicology. For example, we could assess the blood levels of lead. We could check for hemosiderin levels. We could check for levels of protoporphyrin and things like that. Okay, so we'll get to that later. Now, when you encounter a patient with acute interstitial nephritis, there are, as we've discussed, very limited numbers of differential diagnoses, and those differential diagnoses then need to be evaluated a little bit further. So there are some clinical considerations specific to each of these differentials. So I'm not going to go into the systemic autoimmune rheumatic diseases that cause interstitial nephritis because further, because I've already discussed the relevant findings in IgG4 related acute and chronic interstitial nephritis. With SLE and Sjogren's, essentially they form part of the continuum of the disease, and we'll be discussing them as part of the disease. Similarly, in sarcoidosis, it's primary nephrocalcinosis, so I'm not going to go into that. Although sarcoidosis can cause granulomatous interstitial nephritis. Now, pathomechanistically speaking, in case of the organ-limited variants of interstitial nephritis, we have obviously tubular interstitial nephritis with uveitis or TINO. We have granulomatous interstitial nephritis, and we have idiopathic interstitial nephritis. Now, tubular interstitial nephritis with uveitis is basically a T cell mediated immune response against the epithelium of the tubules of the kidney. So that is caused by a Th1 polarized and a CD8 plus T cell response. Granulomatous responses obviously are always Th7, Th1 mediated and result in non-caseating granuloma formation. This is very analogous to what happens in sarcoidosis. Possibly could represent an organ limited variant of sarcoidosis, but obviously this kind of assertion is very difficult to demonstrate, um, using epidemiological studies, because essentially you cannot demonstrate causation, you can only demonstrate correlation. And sarcoidosis obviously is a reasonably uncommon disease. Then we have idiopathic interstitial nephritis, in which we have CD8 plus T cells that are infiltrating into the kidney and causing secondary tubular damage. Very similar to tubular interstitial nephritis with uveitis, but again, there is no uveitis clinically. So therefore, that's how you differentiate between the two. Now, all three conditions result in acute interstitial nephritis. So they cause acute kidney injury, which would be oliguric, and there'll be a distension of the renal capsule. So therefore, indeed, there is bilateral flank pain. Now, this is also associated in case of TINO with anterior uveitis, and importantly, the anterior uveitis in these cases is bilateral and symmetric. It affects both the eyes simultaneously, and it usually occurs after the development of interstitial nephritis. So only in 1/3 of cases do you get it before the interstitial nephritis, or indeed with the interstitial nephritis. You typically get it in 2/3 of cases after the development of interstitial nephritis. Now, there are some non-specific constitutional symptoms that occur in patients with TINO. That is fever, arthralgia, anorexia, and unintentional weight loss. And many rheumatologists has been known to follow these, in a expedient manner, and over investigate patients. So, although you can make a case for that, I guess. Um Okay. Now, again, the systemic disorders that need to be ruled out become Sjogren's syndrome, SLE, and because of the uveitis and the bilateral nature of the uveitis, Behçet's disease, although interstitial nephritis does not occur in Behçet's disease. Uh, Granulomatous interstitial nephritis. Okay, before I go into that, now when I say it does not occur, I mean that it would require an alternate explanation. So if you have a patient with Behçet's disease who has interstitial nephritis, it would be expedient to actually evaluate that patient for alternate causes that are more likely mechanistically to result in interstitial nephritis, and not just attribute the interstitial nephritis to Behçet's, because indeed you could miss out on a much more malignant, or must not miss diagnosis that is actually responsible for the interstitial nephritis. Now, in case of granulomatous interstitial nephritis, one must always rule out tuberculosis, at least in places such as where I practice in India. Also, sarcoidosis in the relevant clinical scenario. So, look for mediastinal lymphadenopathy, particularly on a chest X-ray. Now, in case of hematological malignancies and causing acute interstitial nephritis, we've discussed that chronic lymphocytic leukemia causes interstitial nephritis through direct infiltration of the interstitium by malignant B cells. And this causes secondary tubular damage, which then causes desquamation of the epithelial cells into the tubular lumen, causing obstruction of the tubular lumen. Whereas in case of light chain deposition disease, as we discussed, kappa light chains are filtered in the glomerulus and bind to your TAM phosphol protein. This also happens in multiple myeloma. So in multiple myeloma, lambda light chains are filtered and then bind to TAM phosphol proteins and then get deposited there. Now, the thing is that there is direct obstruction. The coagulation of these proteins occurs due to dehydration as the fluid passes into the filtrate passes into the thin descending loop of Henle, because the thin descending loop of Henle is only permeable to water. So water goes out into the renal medulla, resulting in increased osmolarity of the filtrate, and that increased osmolarity of the filtrate causes these proteins to coagulate and obstruct. Okay. Now, although I've shown it as light kappa light chain, please remember lambda light chain related obstruction is what is called myeloma kidney. Kappa light chain related obstruction would be called light chain deposition disease, and much is actually much more likely to result in a incidental finding rather than a proper interstitial nephritis. And importantly, we've discussed this as a cause of your nodular sclerosing glomerulonephropathy in previous discussions, and also as a cause of glomerular deposition disorders. Okay, so, and if you would remember, among in the very the previous discussion that we just had, it's actually the lambda variant of light chain deposition disease that actually gets deposited within the proximal convoluted tubule, result as a crystal, resulting in light chain crystal proximal tubulopathy, which is the one that actually is associated with clinical presentation as interstitial nephritis. Okay, so it's a little confusing. Uh, so just to reiterate, multiple myeloma related lambda child light chain deposition within the lumen of the tubules causes myeloma kidney, which is the most common thing that we encounter. Now, our plasma cell discretions can also produce kappa light chains, and that when it gets deposited within tissues is called kappa light chain deposition disease. Now, kappa light chain deposition typically occurs within the glomerulus. Okay, and within the glomerulus, it produces a spectrum of diseases that we've discussed previously. Now, it can also get deposited within the proximal tubules, the proximal convoluted tubules, where it is then called light chain proximal tubulopathy, LCPT. Okay, and light chain proximal tubulopathy is less commonly also caused by the deposition of lambda light chain, and in that situation, that is when interstitial nephritis can occur. Okay, so they are. I would suggest you think about it yourself and make it crystal clear in your brain. Okay. Now, again, because of the direct tubular lumen obstruction, there is back pressure, and tubular epithelial necrosis occurs because of the back pressure, as there is edema within the interstitium of the kidney, and that decreases renal blood flows into the medulla. And because of that, we end up having a release of damage associated molecular patterns and an aggressive inflammatory infiltrate into the interstitium of the kidney. Then we have a Th1 polarized response resulting in M1 macrophage formation and eventual, granuloma formation and rupture. Okay, so this is again something that we need to understand. Foreign body granuloma responses occur when you have interstitial nephritis secondary to tubular obstruction, and then rupture of the contents of the tubular lumen into the interstitium. And this is a very important thing because it causes confusion with granulomatous interstitial nephritis. Granulomatous interstitial nephritis, the granulomata are not foreign body granulomata. They are non-caseating, poorly circumscribed granulomata, characteristically seen in sarcoidosis and therefore cause sarcoidal granulomata. These are foreign body granulomata. Okay. Now, the clinical presentation is obviously oliguric acute kidney injury. Uh, in case of chronic lymphocytic leukemia, you end up getting very large kidneys. Okay, so there is massive nephromegaly, and this is one of the causes of nephromegaly. In case of light chain deposition disease, additionally, you can have proximal renal tubular acidosis and Fanconi syndrome. So, please understand, light chain related renal damage is actually a spectrum of things, and sometimes they can overlap clinically. So, one must be, aware of the how they present, and then therefore suspect the appropriate disorder in the appropriate clinical setting. Now, the tubular obstruction can also occur due to acute urate nephropathy, acute calcium oxalate nephropathy, and acute phosphate nephropathy. So, obviously, acute urate nephropathy happens with acute tumor lysis syndrome. Acute calcium oxalate happens due to toxin exposure, that is due to ethylene glycol toxicity, or it happens due to ileal resection. Then acute phosphate happens immediately post bowel wash using phosphosoda, which is not normally done, but is nevertheless a question that is routinely asked. Now, an important thing is that there is oligouric AKI in these situations, and the crystals also cause, they get some of them, get filtered and they reach the distal or the lower urinary tract, and there they can cause a little bit of hematuria. So you get gross hematuria in these cases in some situations. Now, coming to the considerations that we have to entertain during the evaluation of chronic interstitial nephritis. Chronic interstitial nephritis warrants very specific evaluation of metabolic causes. So that includes nephrocalcinosis and chronic urate nephropathy, in which case you have tubular obstruction by calcium phosphate or uric acid crystals respectively, and secondary interstitial crystal deposition. Hypokalemic nephropathy, which causes a significant chronic medullary ischemia. Uh, then hyperoxaluric nephropathy, where you have oxalate crystals getting deposited in the kidney, very similar to what happens with nephrocalcinosis and chronic urate nephropathy. Now, nephrocalcinosis typically causes nephrogenic diabetes insipidus. It is because the deposition of calcium is more towards the inner regions of the medulla, because of the reasons that we've discussed previously. And so this is because the distal convoluted tubule and the cortical collecting tubule are predominantly affected. There are reasons behind this, because these are the two sites of the tubules that are primarily involved in calcium reabsorption, you know, in a paracellular manner. So that is why these parts are affected, predominantly. Now, in addition to that, all causes, that is chronic urate nephropathy, hypokalemic nephropathy, and hypercoxaluric nephropathy, have a gradual, persistent, progressive, march towards chronic kidney disease. But in these situations, the urine output is typically spared. So the patient, often till very advanced stages of renal dysfunction, has a normal urine output. Okay. Now, next, we come to cardiomegalich interstitial nephritis and sickle cell nephropathy, the genetic causes, and I've just discussed FAN1 mutations result in defective DNA repair in the proximal convoluted tubules, resulting in early PCT failure. So these patients initially present with proximal convoluted tubule dysfunction, that is your proximal RTA and Fanconi syndrome, and eventually progress to in chronic interstitial nephritis. Now, in case of sickle cell nephropathy, I've discussed in detail why sickling occurs in the vasa recta, and that results in your presentation with uh, again nephrogenic diabetes insipidus first. That is because the the inner regions of the medulla are obviously going to be affected more, because they have osmolarities of as high as 1200 milliosmoles. Okay, and that is followed by a distal, not a distal, type 4 RTA, that is due to decreased renin secretion rather than a distal RTA, that is a proximal RTA. So the type is always type 4 more than 1, and this is a very important clinical distinction. Now, eventually, the patient progresses to developing secondary FSGS as sickling starts to affect the glomeruli as well, and eventually, the patient develops a CKD. Now, finally, toxins as a cause of chronic interstitial nephritis. Now, there are five important toxins that I would like to highlight. There is analgesic nephropathy, there is aristolochic acid related nephropathy, lithium associated nephropathy, calcineurin inhibitor associated nephropathy, and heavy metal toxicity related nephropathy, which is basically lead and mercury nephropathy. Now, these I see clinically relatively commonly. The others I do not see. Okay. Now, analgesic nephropathy was classically described when patients used to take a combination of phenacetin with the aspirin and caffeine, primarily for headache relief. Um, this resulted in concentration of the drug within the renal medulla in the thin and ascending and descending, descending and ascending uh, loops of Henle, and which resulted in eventual deposition of these chemicals within the medulla, resulting in the production of reactive oxygen species and papillary necrosis. Okay, renal papillary necrosis also, however, is most commonly caused by diabetes mellitus. Okay, also is caused by sickle cell anemia and can be caused by reflux nephropathy. So these are the other three causes of renal papillary necrosis. They are much more common than analgesic nephropathy. Now, aristolochic acid is a type of is a organic compound present within Chinese herbal medications, or can also be present in grain that has been adulterated with aristolochic acid. Again, very rarely seen in the scenarios in which I practice. It causes chronic interstitial nephritis. Okay, so unexplained epidemics of chronic interstitial nephritis in a general area might prompt evaluation for this. Okay. Now, lithium is a rather interesting element. It is obviously in the same column as sodium in the periodic table. So, is structurally similar and accumulates within the principal cells of the collecting tubule, entering through the epithelial sodium channels or the ENaC channels. And then once intracellular, it does its own thing and inhibits a enzyme known as GSK 3 beta. You may recall that this is an enzyme that is part of the your APC beta catenin pathway, or the pathway that degenerates beta catenin in the WNT beta catenin pathway. Okay. Now, this secondarily results in a reduction in ADH production, which is mediated by a basically the results in your aquaporin 2 expression getting decreased, and then there you have chronic interstitial nephritis resulting in developing in about 10 to 20 years of exposure to lithium. Now, again, this happens typically when there are relatively high levels of serum lithium, and therapeutic drug monitoring is not being done, and eventually there is a large cyst formation within the tubules, because the GSK3 beta inhibition is actually altering the signaling pathways within these tubules, resulting in an abnormal signaling in the epithelial cells of the tubules and eventual tubular fusion to form these cysts. Okay. Now, calcineurin inhibitor nephropathy is the most common cause of chronic interstitial nephritis that I encounter personally. Okay. However, they can cause both acute and chronic interstitial nephritis. Chronic is relatively more common. This is due to the effects that alterations in calcium metabolism within the endothelium of the vessels that are there present in the renal medulla has the effects that has on the blood flow within the renal medulla. So it can cause endothelial cell activation resulting in vasoconstriction, therefore distal ischemia. Uh, that vasoconstriction can cause a tubular dysfunction resulting in tubulopathy, and you can, when it is more prominent, as we've discussed, calcineurin inhibitors also cause microangiopathic hemolytic anemia in the kidney. Now, again, in chronic cases, you end up getting a segmental involvement. So often there is alternating areas of completely normal kidney and fibrous kidney, which is been likened to the stripes of a tiger. So we'll be discussing this in when we assess histopathology as a differential diagnosis in cases of or histopathology as a aid to diagnosis in the evaluation of interstitial nephritis. Then we have heavy metal nephropathy. Now, this obviously happens due to occupational exposures, and when we talk about toxins and their evaluation, we'll discuss what are the specific manufacturing processes. But very importantly, this is typically during the production of electrical equipment, and during the removal of people involved in the removal of lead paint. Okay. Now, electrical equipment exposure also results in exposure to cadmium, which can also have similar clinical outcomes. Okay. Okay. Now, clinically, there are some specific clinical scenarios in which these disorders present. Analgesic nephropathy presents with gross hematuria and ureteric colic, with nephrogenic diabetes insipidus and normal anion gap metabolic acidosis because of the presence of renal tubular acidosis. Okay. And the kidneys are small and scarred with medullary calcification because there is medullary necrosis. Now, estolopic acid nephropathy just presents with an unexplained CKD with maintained urine output. Okay, and one important thing is often the anemia that is there is completely out of proportion to the amount of renal dysfunction, because the endothelium of the vasa recta is what produces erythropoietin, and that is preferentially being damaged in these situations. Now, in case of lithium, we have an interesting situation where the blood pressures are often spared and there is very minimal proteinuria. Now, eventually, lithium also causes focal segmental glomerulosclerosis, as we've discussed previously. So, that can result in a progressive increase in proteinuria. And calcineurin urate nephropathy, when acute, causes oliguric AKI. When chronic, it obviously causes your patients having chronic nephropathy. But importantly, see, you would expect tubular dysfunction to cause primarily hypokalemia. And in these patients, you can do have a tubular resistance to aldosterone, resulting in hyperkalemia. Okay. So again, analgesic nephropathy causes confusion with obstructive nephropathy. Okay. Aristolochic acid nephropathy, the anemia is very prominent. Okay, that is a pointer to the diagnosis. In case of lithium associated nephropathy, there is very minimal proteinuria or elevation in blood pressure. So you actually have just an elevation in serum creatinine and basically nothing else in a patient who's been getting lithium for a very long time. Eventually, the patient ends up developing FSGS and progressive increase in proteinuria. Now, calcineurin-induced chronic nephropathy has hyperkalemia due to tubular resistance to aldosterone, which would be a type of RTA type 4. Okay. Again, the risk of calcineurin inhibitor related nephropathy is directly related to cumulative dose. So you must consider whether you require continued usage of calcineurin inhibitors in every patient, especially in patients with lupus nephritis class 5 or cases where we start calcineurin inhibitors upfront. In heavy metal related proximal or chronic interstitial nephritis, you actually have a proximal RTA, and that proximal RTA, as we are aware, proximal RTA is associated with hyperuricemia, and that hyperuricemia is the pointer to the diagnosis. So here it is the confusion with. So in analgesic nephropathy, it is the confusion with obstructive uropathy. In aristolochic, it is the relatively out of proportion severe anemia. In lithium, it is a relatively normal presentation of the patient in spite of high serum creatinine values and the presence of cysts when you do an imaging. In calcineurin inhibitor nephropathy, it is the hyperkalemia in a patient with maintained urine output and elevated serum creatinine. And in heavy metal nephropathy, it is actually the presence of hyperuricemia. These are the tip-offs that point you towards a specific diagnosis in these cases. And if you're not aware of it, again, you'll miss these, and again, you may lose the window of opportunity to help the patient. Now, because analgesic nephropathy also causes lower urinary tract damage, there is an increased risk of lower urinary tract tumors. This includes all urothelial carcinomas, and aristolochic acid nephropathy is actually a risk factor for renal cell carcinoma. Okay. The other three are not associated with tumor risk, and actually, early detection can avoid these diseases. And as I've just discussed, these are the three that we routinely do encounter in clinical practice. So I would, it's something that we need to again be aware of and be very judicious about while evaluating suspected chronic interstitial nephritis. Now, in this discussion, we've discussed the mechanisms of acute and chronic interstitial nephritis and how they cause peripheral edema by distinct mechanisms. We've derived the clinical features that differentiate between these two types of interstitial nephritis. We've understood the possible causes or the etiologies of acute and chronic interstitial nephritis. We've understood the clinical considerations that arise during the evaluation of acute interstitial nephritis. The distinct clinical considerations that arise during evaluation of causes of chronic interstitial nephritis, and finally, we've understood the very important 5 clinical pointers that point towards those 5 different drugs or toxin exposures that result in chronic interstitial nephritis. So that brings us to the end of our discussion on interstitial nephritis. In the next discussion, we'll be talking about how we use the histopathology of the kidney in evaluating the different possible diagnostic considerations in a patient with interstitial nephritis. And so I'll see you then. Thank you for watching.